Hello viewers, welcome to this week's episode of Health Watch on Anglican Cable Network Nigeria. I am Angela Wenze. Diabetes mellitus, commonly referred to as diabetes, is a group of metabolic disorder characterized by elevated blood sugar levels over a prolonged period. According to the World Health Organization, the number of people living with diabetes increased from 108 million people in 1980 to a staggering 422 million in 2014. In 2015, an estimated 1.6 million deaths was directly caused by diabetes, and this is globally. Recently, it was reported that global prevalence of diabetes amongst adults over 18 years has risen from 4.7% in 1980 to a disturbing 8.5% in 2014. My guest on the program today is Dr. Mosias Emmanuel Obidoa. He's a general practitioner at GIF Hospital and Maternity, Kado Estate, Abuja, Nigeria. You're welcome to the program, sir.
Thank you very much.
It's good to have you here today. So let's start with the statistics. 108 million people in 1980 to a staggering 422 million in 2014. That's a huge rise. What would have been responsible for this high rise in the cases of diabetes?
Essentially, it may look like a high rise, but you find out that in the recent past, methods of diagnosis has increasingly been extended to various countries, and the Center for Disease Control is trying to have a good statistics on diabetes. And I also think that it will keep on increasing until all the countries have good statistics on diabetes. Like in our country, Nigeria, I don't think we have data on it.
Of course.
So the increase, as it were, is essentially due to better diagnostic facilities.
Okay,
yes.
So which means even it's possible that this does not even reflect the true nature of the number of the statistics of people that are, you know, living with
diabetes. Yes.
Wow.
Yes, because even though they say that it's commoner with Africans, Hispanics, Asians, and so on, but in Africa, how many countries have statistics of the prevalence of diabetes in their countries?
Wow. So this is, even the statistics just ruled out, it's even a joke. So this is a very serious matter that,
yes,
you know, requires discussion. Okay, now the definition of diabetes, it's clear that it's, you know, it's characterized by elevated blood sugar.
That is the hallmark.
Okay, that's the hallmark.
Yes.
So it's not just going to the hospital and finding out that you have, you know, high level sugar levels, and then we conclude that you're diabetic. It had to be over a period of time.
I may add one or two sentences there. One is that if there is high blood sugar in your system, the doctor must have taken a history.
Okay.
In our climb here, people may go for treatment in private hospitals, in other medical facilities, where they will give them dextrosaline or any of these infusions, parenteral infusions containing glucose or dextrose. If you test somebody who had just taken a dextrosaline solution the previous day, but if his ailment is not getting better and you now rush it to a big hospital and they run tests, they may have a very high increase in sugar level, but that doesn't make the person a diabetic. So a good history is very relevant. Yes, that's why you must tell your doctor everything.
Yes.
Yes, there's nothing to hide. Because that one, over a few days, your body will regulate it to normal. Yes.
So you can't just conclude. So somebody just goes and checks the fasting blood sugar, I assume, and you say, oh, my sugar level is a little high, and you conclude, oh, I'm diabetic.
He must give you a history.
You have to have a history.
Because if he comes and it's high, then say, have you been on treatment? What drugs are you taking? And things like that. Before you conclude.
That's wanted to just note that clearly, so that people don't assume what's my sugar, because the conception is anything diabetes, of course, sugar. Once you hear
the
sugar,
hallmark is high
sugar.
blood sugar. But in the past 1 week, if you are not on treatment, and you have not taken any parenteral infusion, then we can say this is suggestive.
Suggestive.
Yes, and they will do maybe a confirmatory test.
Okay.
But even the glucometer is enough good test.
Okay, to do the monitoring.
Yes, to do the monitoring. Not only monitoring, to even say you have diabetes.
Okay.
Because the machines are precision machines.
Yes, okay. All right, so let's look at the types of diabetes, because, you know, they're not all the same, although all of them have these singular characteristics of elevated blood sugar.
Blood sugar, yes.
So what are the types of diabetes that we have?
Well, in the books, it's type 1, type 2, and though rare, not commonly, gestational diabetes.
Okay.
Yes. The type 1 occur commonly in children. That's why they say it's juvenile diabetes. The type 2 goes with middle age, advancing age, may come before 40 years, but usually 40 years and above is a risk factor, particularly in this environment where we are carbohydrate addicts. We eat carbohydrate every day in this part of the world.
Yeah.
And then the gestational diabetes, as the name sounds, pregnancy-induced diabetes, because pregnancy is also a physiological stress.
Okay. All right. Okay. I'll just take the diabetes, you know, the different classes by one, and, you know, just talk around it. Type 1 diabetes.
Yes.
Is juvenile, and it's just occurs. Would it be that it was genetic in the family and then the child develops it from birth, or it's just random? Is it something can we look at it that way?
Well, it's not genetically proven, but it's familial.
Okay.
Because no chromosome or gene locus has been identified. As once that locus is not there or is altered, you present with diabetes. But we know that in families where either the parents, first relatives had diabetes, you cannot rule out that it's a higher risk for a person born in that family to be predisposed to having diabetes. And that is why we say such things are risk factors, because it occurs more in those that have the risk factors than others. The pathophysiology, as they claim, that the pancreas, which is the organ that produces insulin, that helps in the metabolism of glucose, that the patient's pancreas rarely does produce insulin. It's either absent or is very small. And imagine a small child whose pancreas are not producing. It may be due to abnormality congenitally in birth, but they are acquiring an autoimmune process where the patient's body is identifying the islet cells producing the insulin as a foreign body, and they're attacking it.
Wow.
So some say it's an autoimmune process, but nothing certain.
Okay.
Yes.
Okay. So this when a child comes down, it still presents the same. So when the child is born, it starts from birth, or it's over a period of time at early age you find
very early age, 2 years, 3 years, 4 years, or even 5 years, the child presents with diabetes.
So you just notice that the child just has elevated blood sugar.
You just don't notice. The child will be either urinating so much,
the symptoms,
and that frequent urination, even at night, because you can't count how many times the child goes to the loo in the day, but in the night the child may go out too often to wee, eats quite heavily, but it's not adding much weight.
Wow.
And then if you go to the doctor and tell the doctor, they may suspect urinary tract infection, and they will run what they call basic tests.
Okay.
And if they now find out that the child has elevated blood sugar, because we have a range.
Mm-hmm.
We have a range between 70 milligram per DL,
okay,
deciliter, to 120 milligrams per deciliter.
So this is the range
of normal blood sugar.
Okay.
If it goes below this, you think of hypoglycemia.
Okay. Yeah.
If it goes way beyond this, up to 240 milligrams per deciliter, it's hyperglycemia.
Okay.
And each of them presents with its own problems when you are controlling it.
Okay, so these children just have the blood sugar levels
elevated over this range.
120, this range, they're way above. So the symptoms they come with at that early age is constant urination.
Yes.
And you eat and you're losing weight.
You eat more than usual and you are losing weight. And if the child do not commonly present with any wound, the wound doesn't heal readily.
Wow.
Because this sugar is circulating in the blood system, and that blood system is wired all over the body like pipes.
Wow.
So with sugar there, the wound, the healing process is is delayed. And as they get older, if it's not controlled, the blood vessels have deposits in the blood walls, blood vessel walls, and that will also make blood flow there to be poor.
Wow. Because
healing is accentuated by good
blood
supply in the region. Yes.
And this kind of diabetes, do they live normal life? Do they still live long? Of course, I'm sure they must have to get insulin from somewhere, which is the
this type of diabetes, they live long, because diabetes is just the problem which why people don't like it is that it's the chronicity. Once you control it, this type of diabetes is controlled only with insulin.
Okay.
Because you have to provide insulin that allows the glucose to enter the cells.
Of course, yeah.
Once the glucose does not enter the cell, it's just circulating. So if you give insulin, it opens the cell wall, glucose enters and fixes to the receptors, and then your body uses it.
Okay.
So that's why theirs is a bit difficult, because insulin is not like paracetamol.
That you can just pop in your mouth.
Yes, and you also have to have an injection syringe to do it.
Oh.
So it becomes a Herculean job in an environment where poverty is so rife.
Wow. That's quite disturbing, because a child is just born into it and
suddenly they make a diagnosis of diabetes, juvenile diabetes. It's a Herculean thing. It's Herculean.
But it's not very common, is it? It's not very. It's not.
Like, we don't have the statistics, but
of course,
if we do, some of them, once they cannot manage it, particularly in our rural communities, they pass on.
They pass on, and you think you blame it on something else.
Yes, you blame it on something else. So even if they are here in Nigeria and we don't have the statistics, you either have to have these extension workers
going into the home,
in the communities, so that they'll be recording such things, and they are collating the figures together and be able to know. Because once they are there, they'll keep on monitoring the child in their homes. You say,
that's how you know.
How you know
that something
and how long they survive. It started at so and so time, and by so and so time, the child has passed on. And you'll be following them. If they are having complications, you also record it.
Yes.
And then maybe they further go to ask doctor, why is it like this? They say they have gone out of, presenting themselves in the hospital for management and for monitoring. You understand? Okay,
but it's a standard practice, though, that the kids in hospitals, the ones that go to the hospital
will survive. Yes, survive as long as.
More of the issue of poverty and the people in the rural areas. Well, we'll talk about the whole other part of the ignorance. But now, gestational diabetes. I want to take that one next. Now, this one is just because a woman got pregnant and that's why she developed.
Yes, if there is that propensity to develop diabetes, because one of the risk factors is stress, And like I mentioned, pregnancy is a physiological form of stress. And the woman who is pregnant is a different physiological person than the woman who is not pregnant. You can understand that once pregnancy starts, the normal daily chores the lady does becomes Herculean.
Okay.
Because of her respiratory alterations due to the pregnancy. So also our sugar level, control of sugar level is also affected. Even the clotting mechanism is also affected because the body is being prepared for eventual delivery.
Okay.
So that stress on the lady makes some women to be tipped over to having diabetes in pregnancy.
Okay, we'll just hold that thought here. We'll come back after a quick break and then we'll continue discussion on gestational diabetes. So don't go anywhere, viewers. We'll be right back to continue this discussion. Hello, viewers. Welcome to this segment on Health Watch. Today, I shall be talking about diabetic foot ulcers. Foot ulcers are a common complication of poorly controlled diabetes, forming as a result of skin tissue breaking down and exposing the layers underneath. They are most common under your big toes and the balls of your feet, and they can affect your feet down to the bone. All people with diabetes can develop foot ulcer, but good foot care can help prevent them. Treatment from diabetic foot ulcers and foot pain varies depending on their causes. Discuss any foot pain or discomfort with your doctor to ensure it's not a serious problem, as infected ulcers can result in amputation if neglected. Let us run through the causes of diabetic foot ulcers. Number 1, poor blood circulation. This is a form of vascular disease in which blood doesn't flow to your feet efficiently. Poor circulation can also make it more difficult for ulcers to heal. Therefore, if you're diabetic, avoid any dressing or sitting position that will obstruct blood flow in your body. High glucose levels, also known as hyperglycemia. They can slow down the healing process of an infected foot ulcer, so blood sugar management is critical. People with type 2 diabetes often have a harder time fighting off infections from ulcers. So take your medication as prescribed by your doctor, eat healthy foods, and adhere strictly to all advice from your doctor. Nerve damage, that's number 3. This is a long-term effect and can even lead to a loss of feeling in your feet. Damaged nerve can feel tingly and painful at first. Nerve damage reduces your sensitivity to foot pain and result in painless wounds that can cause ulcers. Irritated or wounded feet. This refers to various cuts and injuries on the skin by a sharp object. In a normal person, there is an immediate clot which leads to healing. However, in a diabetic person, this cut, if not well attended to, can lead to foot ulcers, especially when the blood sugar is high. Let's look at some risk factors for diabetic foot ulcers. All people with diabetes are at risk for foot ulcers. However, there are some factors that can increase the risk of foot ulcers. These include poor hygiene, not washing regularly or thoroughly, alcohol consumption, eye disease caused by diabetes, obesity, tobacco use. They inhibit blood circulation. Even things as simple as improper trimming of your toenail or poorly fitted or poor quality shoes. What are the symptoms of diabetic foot ulcers? One of the first signs of a foot ulcer is drainage from your foot that might stain your socks or leak out into your shoe. Unusual swelling, irritation, redness, and odors from one or both feet are also common early symptoms of a foot ulcer. The most visible sign of a serious foot ulcer is black tissue, called eschar, surrounding the ulcer. This forms because of an absence in healthy blood flow to the area around the ulcer. Another one is partial or complete gangrene. that appear around the ulcer, known as tissue death due to infection. In this case, odorous discharge, pain, and numbness can occur. That is, you cannot feel any pain around this area. It is also important to note that signs of foot ulcers are not always obvious. Sometimes you won't even show symptoms of ulcers until the ulcer has become infected. Talk to your doctor if you begin to see any skin discoloration, especially tissue that has turned black, or feel any pain around an area that appears irritated. Treatment: stay off your feet to prevent pain and ulcers. This is called offloading, and it's helpful for all forms of diabetic foot ulcers. Pressure from walking can make an infection worse and an ulcer expand. For people who are overweight, extra pressure may be the cause of ongoing foot pain. The most important treatment is to adhere strictly to your doctor's instruction. Go to the hospital for proper treatment of ulcer. Do not apply any tradomedical recommendation to the ulcer. If you're not sure about anything with regards to your foot ulcer, please speak with your doctor. Infection of a foot can be prevented with foot baths, disinfecting the skin around an ulcer, keeping the ulcer dry with frequent dressing changes, enzyme treatments, and dressings that inhibit bacterial growth. This, however, must be discussed with your doctor before usage. There we have it, the basic things we need to know about diabetic foot ulcer. But before we go, the Bible says in Proverbs 4:22-24, "My son, be attentive to my words. Incline your ear to my sayings. Let them not escape from your sight. Keep them within your heart, for they are life to those who find them, and healing or medicine to all their flesh." Also, Psalm 107:20 says, "He sent out his word and healed them and delivered them from their destruction." It is important to declare the word of God over your body every day and believe strongly in God's word. The word of God is a medicine with no danger of taking an overdose. It has a documented history of changing any physical body it comes in contact with. It will surely prevail over any sickness or disease, including diabetes. So, feed on God's word, declare it over your body, and you will have a testimony. If you have any question, please contact us with the information showing on your screen. If you would like to sponsor this program, please contact us with this information. Join me again next week on this segment of Health Watch. God bless you. Welcome back. Before we went on the break, we were discussing diabetes with Dr. Mosias Emmanuel Obidoa. So, sir, gestational diabetes we were discussing. Now, you know, it's as a result of the woman, you know, the stress that she goes through during pregnancy could be responsible.
The pregnancy per se is a stressful factor.
Okay, factor that brings about,
yes,
you know, this diabetes. Now, does it have any linkage with this, the type 1 diabetes? If she gives birth to a child and she has this elevated sugar, will the child come out with some form of diabetes as well, or is there a treatment that protects the child from
there is no treatment that protects the child in the womb, but the woman will be encouraged, they will be treated like any other diabetic patient with oral hypoglycemics.
Okay.
That is the anti-diabetic pills.
That's okay.
But by the time the woman is getting to term, they will change the woman to insulin because of better control.
Okay.
Yes.
That's serious.
Yes, because if no two pregnancies, you know, can be the same.
Okay.
So the labor can start well, but somewhere along the line, anything could happen. Dystocia, weakness, fetal hypoxia, and all kinds of things. And you have to go into section and bring out the baby.
Okay.
You cannot do it with somebody on oral hypoglycemics.
Okay.
So it's because of better control. That is one. Two, children of diabetic mothers usually add weight. So they come as big babies.
What? How does that? Is it just normal? It just happens.
It's an observation.
Just observation. Okay.
Yes, that they weigh usually above 4 kg, but that is not an absolute figure in modern times, where good living and people can afford living well. So if you have a big baby, you have to run some investigations on the baby and even the mother. A child that is above 4.0 or 4.5 kg at birth is usually suggestive, and they are floppy, and I think they need more serious neonatal attention.
Okay.
Because they are floppy. They are not too strong. Maybe the respiratory system or any of those things, I can't go into that because it's not my field.
Yes, okay.
But they are special children. You have to manage them well so that they can kickstart their life without turbulence.
Oh, right.
Yes.
Okay, so now the children, of course, to be cared for. The mother, when after delivery, does it go away? Does she just not have height, or she now starts suffering diabetes for the rest of her life?
No, she doesn't start suffering. Some of them, after maybe, because you have to manage them up to about 6 weeks, which is postpartum.
Okay.
And as you're monitoring them, once the sugar level has stabilized between 70 and 120, you tail off the drugs gradually. And
reduce the number of times they have to take it.
Yeah, as it's going down, you are reducing. As it's going down, you are reducing. And most of them will not continue with diabetes after the pregnancy. You understand? But if you may continue, and there's nothing you can do about it. So
even when they develop, they still have to be careful what they eat as well?
They have to, yes. In pregnancy.
In pregnancy, yes.
Yes, because the baby is a parasite, an absolute parasite. So if the woman is managed well, the outcome of the pregnancy at 10 will be better for the baby and for the mother. So the mother will be, a dietitian will tell the mother what she should be taking. Because management of diabetes is a team work, knowing that it affects so many other organs in the body. Yes.
We're going to come to discuss how diabetes leads to death, but that's as we go on in the but when she's done with, can she conceive again?
Of course. It doesn't affect fertility.
Okay.
It doesn't affect fertility at all.
You know, sometimes people bring up stories about things that affect, you know,
diabetes
fertility.
Doesn't affect fertility. What it does affect is the outcome if it's not managed.
Okay.
Yes.
Okay. Are there factors that predisposes a woman to this gestational diabetes? As in, is it something that you notice earlier and then you said, oh, when I'm pregnant, I'm most likely going to have elevated sugar, or have diabetes during pregnancy, or it's just a random thing that happens to?
It's more of a random thing that happens. But you know that in the antenatal clinic, which every pregnant woman must be encouraged to register in a proper hospital, they run all these tests, basically, and they advise them on how to eat, their meal plan, they take their BP, and do all these tests that will help the woman do well in pregnancy. So if they stumble on high sugar level, they may now send you to see your doctor again, that will review you, and they'll keep an eagle eye on you. If you continue, they start managing you. Yes.
But does it eventually have anything to do with somebody developing high blood pressure? Is it related, or it's a
the relationship of diabetes is high blood pressure is one that the high blood pressure occurs commonly, that is the primary hypertension of undetermined cause, occurs commonly in people that are aging. That is, the stress of life comes up usually at middle age.
Yes.
We have a small population that is classified as secondary or surgical hypertension.
Okay.
Yes, that other things can be it, and the people that suffer it are much younger, can even start at 20 years, 21 years, and so on. And the pressure level spirals, and you cannot understand it, but when doctors start their investigation, they can locate what the problem is. But in this middle-age diabetes called type 2 diabetes, you find out that somebody who has diabetes is a high-risk patient for hypertension, and vice versa, because the lipids in the system, the high-density lipoproteins, the good fat, the low-density lipoproteins, the bad fat,
but the final stage of,
and the triglycerides. Yes, they are the bad ones that, because of their size, they enter the cells of the media of the blood vessels, and when they stay there, they cake, and won't allow the blood vessels to be compliant. Once the pressure is pushing, they are supposed to gradually expand small and help in the forward movement of blood as they compress. But once they cake and they become atherosclerotic, it's like a lead pipe. All the pressure is transmitted, and that raises the pressure. So you can see with such things as fat, the LDL, the triglycerides, which is common with those who are obese. It's a high risk factor for diabetes.
Okay, I was going to come to that for type 2 diabetes. Now, this is the one that has the higher population of people that suffer from it. But this, before we go into the adult, because earlier you said over 40,
40 or 45 years.
40, 45
it's a high risk.
It's a high risk.
It's an aging disease.
But recently, you're hearing kids coming down with diabetes. I understand there's some young people, 12, 13,
that is under the juvenile diabetes.
Okay. Now, this heightened number of people, before, of course, the data is not always available, even as it was before and now. But is anything changing in us that is making us have this constant high sugar level, especially with type 2 diabetes, which is non-insulin dependent? No, it does not. That's the one that's...
The juvenile is insulin dependent.
Yes.
The type 2 is not insulin dependent. It can be managed strictly by exercise. And good dieting. Even though those that cannot completely be managed by these two can be managed using insulin or oral hypoglycemics as well as exercise. You understand? So if you look at Nigeria in the past 15, 20 years, it's like the oil boom has made families have excess. So they eat to appetite, and when somebody eats beyond what he needs, and mainly carbohydrate, I said we are carbohydrate addicts. It's either you eat swallow, the other non-swallow rice, and if you have better means, butter is sweeter than margarine. You think that you are living well, except you are advised. And very few people go for aerobics, exercise.
So lifestyle has actually changed over the...
You took it out of my mouth. Lifestyle has changed tremendously.
So that could be responsible for why people are coming down with this type 2 diabetes over the years, because we're becoming...
Lifestyle. They don't exercise. Most jobs are sedentary. What we consume, and maybe not even having enough rest.
Not having enough rest?
Rest. Yes, because rest is not just switching off your brain. Nobody can switch off his brain.
Mm-hmm.
If you sleep 6 hours a day,
So if you, well, okay, if you're not sleeping enough,
you're not sleeping.
So maybe the stress
because
factor.
Sleep is the perfect rest.
Yeah.
Sleep is the perfect rest. So you are there, you are not resting, you are eating beyond what you are supposed to, and the other thing that does not make for healthy living, because if you are so stressed, it predisposes you.
Okay.
To having diabetes. Yes.
So does it differ between men and women? You know, of course, we have women that outside the pregnancy, gestational one. Does it differ between men and women? The people that come down with diabetes, or it just cuts across everybody? One
of the risk factors, as we learned, is obesity, being obese, and it cuts across men and women. They didn't distinguish whether if a woman is obese, she's protected or not. You understand? So I would say it doesn't, women are not shielded from having diabetes, even when they're obese, even when they are above 40, 45 years. If they expose themselves to severe stress, you understand. Because even some women work harder than men these days.
Of course, yeah.
Yes, so.
Okay, so basically now it doesn't matter if you're male or female. If you're obese, you know, you predispose yourself.
Yes,
to
you're a high risk patient.
Okay, so when people, what happens? Is it you know, like when we talked about the type 1 diabetes, you see that the islet cells are not responsive. They've been destroyed by
an autoimmune, by a suspected, it's a kind of hypothesis.
Yes.
Because if it is certain, it will be written in black and white that juvenile diabetes is autoimmune based. Okay.
All right. We'll just go on a quick break, and when we return, we'll discuss more on the treatment or how to manage the diabetes in itself. All right, viewers, we'll be right back to discuss more. See you soon. Welcome back, viewers. Before we went on the break, we were discussing diabetes with Dr. Mosias Emmanuel Obidoa. Thank you very much, sir, for all you've been educating us on and letting us know. Okay, now, this type 2 diabetes, you know, when we talked about the type 1 diabetes, we saw that it is the islet cells we're not responding to what it's supposed.
They are not producing, or when they produce, they are producing very little.
Very little. That's not enough to regulate sugar levels. Now, in the case of type 2 diabetes, is it still working in the same mode, or is it a different mechanism? Yes.
Well, the islet cells produce insulin, and insulin is the main thrust of glucose metabolism in the body. But in the type 2 diabetes, you know, the person has been managing his life well, and suddenly he comes down with inability to manage the sugar, and the sugar starts rising in the blood. Okay. So what happens is that the insulin that is produced may not be enough, or that the insulin produced is not properly used by the body, either through the muscles, entering the muscles. So it's not a case that insulin produced is not enough, but it's not properly used by the muscle, or because the person is so obese, the quantity has relatively become less than what the patient needs. Okay. Yes.
All right. So if I understand that clearly, the insulin is being released.
It's being released, but the person needs more insulin to meet up his metabolic needs. And if he's not doing that, the sugar will rise. Or even if the insulin is enough, the body is not using it appropriately because it has to enter the cells.
All right. Okay. So the mode of action, which is normal routes for insulin, is no longer. It's been affected in this way. Okay. Now, people that have that, does it have any genetic? Is it genetic? Is it as a result, maybe your father has diabetes and you must get diabetes at some point in your life?
No, like we talked of risk factors. Somebody who has parents that had diabetes has a higher chance of having diabetes. But there's no chromosome that they can pin down, which if you have a problem of that chromosome, you must come down with diabetes. And that is the language of the doctor who says that this disease is sex-linked. This is this. If you have, like in Down syndrome, trisomy 21, that the chromosome 21 is 3.
Okay. So it's certain about this is the problem.
Yes, once you have 3 chromosomes in chromosome 21, you come down with Down syndrome. You understand? It's not like that. But we know it occurs in family, but maybe with more research, we may be able to stumble into what if you have, you must come down with diabetes. But for now, no. Okay. That's why the best we can say is that it's familial.
It's familial. Okay.
Yes.
That's a better word to use. So it's familial.
Yes.
Okay. So it's likely that if your parents, you know, go down, have diabetes,
or first-degree relative.
Okay.
You watch yourself. By the time you are 40, you try to regulate your diet and eat. Have a good meal plan for yourself.
Now, this type 2 diabetes, is it always lifestyle related? The food, say you're eating, is it because you eat a lot of sugar? Or you eat, you know, some people feel, you hear it common everywhere. Someone say, all the sugar you're taking, be careful, oh, there's diabetes, you know. Is it because you're taking high level sugar, you know, content food or sugar-rich food, then it means at some point you will come down with diabetes.
It's not a straitjacket thing. You can see people who are fat, who eat sugar, bakes cake, eats, you check their sugar level, it's even bordering on hypoglycemia.
Okay, the diabetes is releasing more insulin.
Yes, because I've had cause to advise some people who are close to me, and we went further to do the fasting blood sugar, and they are bordering on hypoglycemia. So it's not a straitjacket thing, but it's commoner that if you have the risk factors, your age is above 40, 45, you are obese, your basal metabolic index is high, your...
how do you mean basal?
They have to check your weight, your height. and
Ojimas index.
Yes, yes.
Okay.
And then people who are under severe stress, people who are hypertensive. But yes, by the time you get to, you are a good candidate of having diabetes.
Wow.
So you better, if your BP, you manage it well. If you are eating so much, you try to work out. Don't live a life of inactivity, because as you work out, this sugar is being burnt. Yes. So if you do all those things, the caution or cautionary statements the people give to their friends and relatives is because of the chronicity of the illness. It will deplete your resources. You will not be comfortable. So it's a show of love to remind them that this diabetes can happen, and most of them don't end well. Some have chronic ulcers because they cannot have a perfect control, and they die in misery and discomfort. You understand?
Alcohol, does it predispose somebody to, high consumption of alcohol? Alcohol, I mean your beers and your...
alcohol is not encouraged, because where you take the alcohol is not in the parlor of your house, in your living room. You go out, a lot of things goes with alcohol, and when you come home, some of them don't eat, some eat so much outside, and alcohol, in essence, if you eat it in an empty stomach, can cause hypoglycemia.
Okay.
Yes.
All right.
Can cause hypoglycemia. So people who go out drinking starve. Some people come back from a drinking bar, they just go to bed and sleep. Yes. And once your system is not working perfectly, you are exposed to infection. You also know that some infections, viruses, can affect the pancreas. And some drugs can also affect the pancreas. And you come down with diabetes. These are predisposing factors. So things that will make you vulnerable is discouraged in all its ramifications.
Okay, so the concept now is, if you to prevent yourself from getting into that level, you manage what you eat. You manage what you eat. You eat more vegetables.
If you take alcohol, one beer a day, one stout a day may not really alter your yes. Once you drink to the point that you become dependent, that you must drink every evening. Yes, become an alcoholic. It doesn't mean that you get drunk, but you become an alcoholic. And you find that some of them, because they don't eat to appetite, some vitamins that help them, like thiamine and so on, they start having some problems from the intake of alcohol, because it doesn't make them eat well, balanced diet and all those things. So alcohol, in a way, is just a general thing that makes somebody not to be having a healthy life. Life in general. Life in general.
Okay, now there's what I want to ask now is, there's this thing of people grinding bitter leaf, scent leaf, or bitter cola. They grind it and drink it because they feel it's a cure. Even sometimes you watch it online, you see somebody, grind bitter leaf, mix so many green vegetables and tell you to drink it, that it's a total reversal of diabetes in itself, which of course we know, we've established you can only manage it from this point. But now there are people coming with this whole thing of mix this and this, the greens, the bitter one, the more bitter it is, the better it is for treatment of diabetes. How true is this, sir?
It's laughable. It's laughable. But I don't blame my people. There is so much poverty in the land. In a third world country with a lot of educated people in Nigeria, the level of ignorance is so high. It's so very, very high. If somebody has diabetes, where do you go? To the doctor. But their sisters, their cousins, their friends who are market women is people that prefer these advices. And depending on the level of respect and reverence you have in
the person,
yes, they take it hook, line, and sinker. But that is not true. They are all vague. You pity the people because if they now decide to be going for checkup, they will pay some little fees to the doctor. The drugs are not cheap because they don't care whether you are poor. There are no drugs for poor people and for rich people. And in Nigeria, we don't have this, how do I put it? I remember I'll say it.
Okay.
Yes. This encouragement of health service everywhere. Like this national health insurance scheme should have gone beyond where we are. We should have been able to capture people who are not in the formal sector. All these artisans, women in the village, the population ab initio is there because it is population based. We know that by statistics, 10 to 15% of people are sick at any point in time in any society. So if you have a clientele of 10,000 people, even in the rural area, and they are paying 500 naira a month, you should be able to treat all of them. You understand? But because it has not been captured, there's a lot of politics into the National Health Insurance Scheme. People are doing all these things. If it is a place where you have diabetes, you walk to the nearest clinic and then you get proper treatment. And what you spend on is about 100 naira. Nobody wants to play with his life. All these things that are said, the background is fear. Fear of death.
So people now decide to help themselves.
Yes, they go back to their backyard, get scent leaf, get onubu leaf, and all those things, and hope
that it will go.
And most of those hopes are in vain because they don't help. If now they come with complications like ulcer or hyperglycemia or go into coma, if something,
and sometimes even if it has some measurement of having any effect on sugar, you can't really see the quantity.
Yes, quantified. And we have universities that offer pharmacy, pharmacognosy, pharmacology. The government should encourage them to try those leaves and
then quantify
it and do the extract, classify them. And that is how medicine improves. It's not by wishes. It's not by, yes. Old herbal remedies don't really work. Those that work is for people who are at the certain end of a dead horse because of poverty. They cannot help themselves.
So so it's completely ruled out. It's not a cure, but it's something that you can actually take on a normal day, you know. Just
why do you take something that you don't know about? What is the dose? What is the side effect? What is the time of the duration of action?
Of course, the half-life, or how long would it take to leave the system?
And when you get the leaves, how do you preserve it before you now mash it or boil it or? It's ignorance.
So the point is, do not go to your medical doctor for proper
check-up and monitoring.
If you notice that you have. So what are the symptoms people should be looking out for when to say, okay, of course, I understand not many people, when they find out they're diabetic, it's maybe they stumbled on it, they went for another test, and then the doctor is checking for something and finds out that I've noticed over a period of time this person has been coming here for heightened, elevated blood sugar. But what are the basic symptoms somebody should, when you notice such happening to you, you should then begin to see if you should, especially when you're over 40?
Yes, the symptoms are definite, but usually the Nigerian patient comes and says, I'm feeling one kind.
You can't put a name to how your body feels.
Because of ignorance.
Okay.
Then you say, how did it start? When did it start? What are the things that you noticed? That is history taking. And they will now reel down that, I noticed these days I'm urinating too often.
Urination, constant urination.
Yes, frequent.
Okay, frequent urination.
And when I come there, I see ants gather around where I urinated.
Okay, that's the common basic, the local way.
So people that have WC cannot say this.
Yes, of course, it has to be out in the open.
Yes. That I'm eating too much. I feel hungry very often. I eat. But I'm not really adding weight. So you have weight loss even after eating properly, you're losing weight. Yes.
Constant urination. If you urinate outside in the open and you notice ants come around, and it means
and you are tired.
Always tired.
Always tired.
Okay.
I cannot put hand on why you are tired. It's not they are doing very strenuous work. And so many other things.
Okay. I hear something about thirst. Today
you are very thirsty. You are very thirsty. You urinate often, you are very thirsty, you feel that you want to eat everything and you are not adding weight, and you are very tired after eating.
Wow. So those are the things people should watch. When you notice such happening to you, please.
You usually go to the doctor.
Doctor, yes.
But I'll say that, I don't know how I'm feeling.
And the one of them, the wound, I know in the villages you see people when they have, there's a name they call it in my language, ochere or something like that.
Yeah, that is, they say,
the Igbo one.
Okay. That is, it doesn't go because the Mwadiani is, you are a Mwadiani to where they married your mother from.
Okay, all right.
So you are in constant relationship with that family.
Okay.
So Mwadiani is a wound that does not go.
Okay.
But usually it's venous ulcers.
Okay.
Because the venous ulcers, because of the arterioles, the small blood vessels, but the arteries are blocked from the sclerosis when the lipids enter their walls.
Okay.
The blood that passes there don't contain oxygen.
Enough oxygen, okay.
So they don't heal.
They don't heal. Oh, but of course, by the time you get to that level, you're already running into big trouble.
No.
Okay.
Because the diabetic wound does not heal, you may be in full life, but you're not out of control
Okay.
because of non-compliance. You're not taking your drugs. You're not monitoring yourself.
Okay. All right.
Because I've had somebody well-to-do, good businessman, he had a cut in his hand and went to see a doctor. For as long as there was sugar in his system, that wound was getting bad.
Wow.
Until they had a perfect control, immediately had a perfect control. For about 2 weeks, the wound healed. So it doesn't matter.
So even if it just good management can help.
Yes. Once the sugar level is between that 70 and 120, for as long as 1 month, your wound will heal normally.
Okay. All right. So what do, we're just wrapping up now. What do people die of in diabetes? Because do they just, is it, oh, my sugar level is high, then I just go?
That's why they say it's a chronic metabolic illness.
Okay.
It is the complications.
Okay.
Yes, even when you are managed, if you miss your drugs and you don't take it seriously, you become hyperglycemic.
Okay.
And when you become hyperglycemic, your body trying to use other means of getting energy will produce ketonic acid. Okay,
I keep seeing it when they write something on ketone. Acidosis.
Yes, yes. And once you have acidosis, it will affect the physiochemical activities of the body generally. It gets to the brain, you go into coma. And it must be managed in a proper hospital. Right. From there you can die.
Wow.
That's hyperglycemic coma.
Yes, okay.
You can also have hypoglycemic coma.
Of course, when the sugar has really gone
too
below.
low. You're either taking it too much to make sure it doesn't come up. You don't know it's in a range.
Oh, of course. All right.
You understand?
So you have to monitor and check as
yes,
well.
Make sure it's in that range. You must be going, or you buy the glucometer. And they are taught
how to use it.
How to use it. You must keep on updating yourself.
Okay.
In hypoglycemic coma, and they are usually told to wear an identity card. I'm a diabetic, you write your name, person to call.
Okay, when there's an
emergency, and so on.
So if you're going to see your doctor, Jennifer, for something else, it's also important to let them know that you're diabetic if it's been established for you.
Yes.
All the time, so that they don't make mistakes.
And you carry an ID card so that you can slump into hypoglycemic coma.
Okay.
And if you don't have anything on you suggesting that you are diabetic, the doctor may first of all think that the first thing that they will do is to give you an IV fluid.
Okay, yeah.
You understand? And you are in coma, nobody can talk for you.
Yeah,
but if they search around your pocket or wallet and see that the ID card, they know what to do immediately. They will just do your glucometer test, and find out the sugar level is about 40 or something. They give you a bolus of sugar. You wake up. And you know that you cannot stay without sugar in the brain for more than 5-10 minutes.
Yes, what the brain goes.
So such things can kill people because they are not properly managing their diabetes well. Part of the management is that ID card.
Okay, so very important for every diabetic patient watching should have an
ID card.
Okay. Is it in every hospital they give it to them, or in Nigeria? Well, in Nigeria where we are. Or
well, you can ask. If you can't ask, you can go to a cyber cafe, write your name, write your next of kin, and write that you are a diabetic, and put it in your wallet.
In your wallet, okay.
Do you understand? It's going to help the person, because like the management of diabetes, I said it's a team work. Your doctor, the endocrinologist, who will be monitoring you, giving you the drugs, the dietitian that will plan your meals and how you are going to be taking them, the kidney specialist, because if the arteries affect the kidneys, the nephrons that do the filtration will die, and you lose some nephrons, and you start accumulating uric acid.
That's another complication on its own.
And that the kidney is failing. That's another complication. Then if you are not monitored well, the hypertension will, or diabetes will leave exudates at the back of the retina. And you have blood vision. And so on. And there are times the nerves are not well nourished through the blood vessels, and you start having areas that are not sensitive.
Okay.
So you can wound your toes, you can wound your foot, and all those things, and those ulcers come.
Wow. But does it at any point lead to stroke? Is stroke a part of it?
The stroke is part of the atherosclerosis that may affect the coronary arteries, and once the coronary arteries clog, there's no supply to the heart. You can have stroke, you can have heart attack.
Wow. A lot to learn on diabetes. It's even more than just the sugar itself. It's more than sugar. It's the complication.
That's why you should manage it very well.
So the message now is go to your doctor when you notice the symptoms that we have discussed, and then when it's been diagnosed and clear, then you should monitor your diet, which is very important.
The doctor will tell you what to do. And you also join a support group if we have such support group in Nigeria, because they will also tell you their experiences, and you avoid it. Okay. But don't, and you also monitor as well. Yes. Monitor your sugar level. What the doctors, you take your drugs, and if it's a fortnight visit, you go.
Yes. Okay.
Because it's your life, and they
don't take treatment into your hands. Like go and start taking.
No, don't. If you monitor and the sugar level is all right, you can go and tell your doctor that I did this. They will do it. They confirm what you are saying and say, let us reduce the drug. It's not the drugs that you started with, you continue for. Okay. That's one.
All right. So that's why it's important to always go to the doctor for monitoring, because they will tell you where to slow down on, or where to carry on, or where to increase.
And at times when you continue treatment, the body system becomes resistant to that particular drug. doctor can change or add something that will make the muscles pick up glucose faster. Okay. As an adjunct.
Wow. Very, very important to monitor. If that's one thing we take home today, it's to monitor.
Once the diagnosis is made,
and you can live a normal life, and
you live a normal life. The only thing is that they also have mental problems, frustration. Okay. Fine, you are working very hard, and they say you have diabetes. You now make money for people and they enjoy it, and you are not eating.
You're not eating. So
you understand? Some of them become frustrated, some of them become depressed. So you have to talk to them.
Okay, they need counseling as well.
They need counseling. They need a lot of counseling, so that they will not take it out on those who are enjoying All
right, I think that's all we can take today on the program on diabetes. And for the past few minutes, I've been speaking to Dr. Mosias Emmanuel Obidoa. He's a medical general practitioner from GILF Hospital and Maternity in Kaduna State in Abuja, Nigeria. Thank you very much for coming on the program today. It's good, and thank you for letting us know this important information that we need, and I believe our audience would have learned so much today from your coming. All right, viewers, thank you very much for joining us today. That's all we can take on the program today. Until we see you next time, have a lovely day and God bless you. My name is Angela Wenze. Goodbye.